everybody. Thanks for coming and thanks for inviting me to talk. My name's Kiel Woodward. I'm a fellow with the Movement Disorders Department at the University of Nebraska. And I think I heard that Dr. Torres has done this talk in the past, and I'm sure he's done other talks for you as well. So first off, I apologize for not being Dr. Torres. But he taught me everything I know about neurology and, in life in general. So I'll do my best to fill his big shoes. And in addition to the teachings from Dr. Torres, I get taught by all the other faculty at the University of Nebraska as well, including Dr. Boddy, Bertoni, Hellman, and Sire, if you've had a chance to meet any of them. And I am a fellow, and for those who don't know what a fellow is, so in your medical school training, you start with med school, and then you graduate med school and you do your residency. And then some people who complete their residency go off and be doctors or neurologists. But then after residency, you can subspecialize even further in a fellowship. And that's what I decided to do. I did my residency in neurology and decided to specialize in Parkinson's disease and other movement disorders like tremor, trouble walking as well. So I work with a lot of Parkinson's patients. Maybe I've met some of you in the past, and I've gotten a chance to work with DBS a lot the last year, and it's been very fun. So just before we even get into the topic of DBS, I just want to talk about some definitions like of Parkinson's disease, just a quick review. I know that most of you either have Parkinson's disease or you have a loved one with Parkinson's disease, so you're very familiar with it. But just a quick definition. So Parkinsonism, not Parkinson's disease, but Parkinsonism, it's a syndrome, and it's diagnosed when there is slowness of movement, aka bradykinesia, if you're familiar with that term, plus either stiffness or a tremor. Not everybody with Parkinson's has a tremor, but sometimes it is there. And there are many causes of Parkinsonism. Parkinson's disease just happens to be one of them, and one of the most common, if not the most common cause of it. Aside from these symptoms, it is a progressive disease. It gets slowly worse with time, and that's characterized by the degeneration of dopamine-producing neurons deep in the brain. So it's a lack of dopamine. And since it's a lack of dopamine, the symptoms that we experience typically respond very well to dopamine replacement, like levodopa and the dozens of other medications that are available for Parkinson's disease. Here's an illustration demonstrating what Parkinson's disease looks like. This one on the left here, made all the way back in 1886, and it's kind of the picture that's present in every single medical school textbook ever. Shows an old man hunched over with poor posture and not being really able to move his arms very well at all. And just last year, they finally kind of released an updated version of what Parkinson's disease looks like, since this was made well before we had treatment available. And now this kind of demonstrates the spectrum a little better, starting with your mild Parkinson's disease on the left, where you can still do a lot of your daily activities and it doesn't affect you too much. And then all the way over here, when it becomes severe and you start looking more like this untreated Parkinsonian patient from all the way back in 1886. So more about early Parkinson's disease. You might not be able to tell someone that you meet for the first time that they have Parkinson's disease in the early stages. They might just have shakiness of the hand on one side. When they're walking, they might have reduced arm swing, like one arm doesn't move as much as the other when you're walking. Decreased facial expressions, what the textbooks call masked facies, like you have a mask on your face. You may notice that one hand doesn't work quite as well as the other. It doesn't do the things that it used to be able to do. Sometimes the handwriting gets smaller, speech gets softer. Some people with early onset dystonia, like in their 40s or 50s, experience dystonia and it's usually in the foot. That's what they're circling here on this woman. And dystonia is just when some of your muscles contract in odd ways and can cause postures or tremor. And it can interfere with running, such as it looks like it would in this woman. And a lot of people experience pain in one shoulder that is kind of unexplained, that we think is due to stiffness or the slowness of movement. The shoulder doesn't work as well. As the disease progresses and it advances after 5 or 6 years, the symptoms that we just talked about with the mild case, like tremor, stiffness, slowness, those become more severe with time. And you may also notice motor fluctuations. I know that some people experience motor fluctuations and know very well what those are. Some don't. So I'm going to get into a little bit more detail about what that means here in a little bit. But that includes a phenomenon called wearing off and dyskinesias. Also, with time, your response to the medications like levodopa, it may start to become unpredictable. So sometimes you'll take a dose of levodopa and it just doesn't work. We call that a dose failure. Or sometimes it works for a little bit, but then suddenly wears off much faster than it used to. And the reasons for that are complex. Usually it's due to like a slowed GI system, like you don't digest it as well and absorb it as well. So that can lead to a dose failure. Or the way of storing the dopamine in your brain, it gets less over time. So that can lead to unpredictable offs. You may experience nighttime off periods where you get really stiff and that makes it really hard to sleep. So some people take medication in the middle of the night just to sleep. Freezing of gait is common as the disease progresses, where your feet get stuck to the floor and it's like they won't listen to you. And then of course, impaired balance and falls and difficulty swallowing can be very bothersome in the later stages of the disease. So I mentioned these motor fluctuations. Once again, some of you know well what they are, but motor fluctuations are just when the medication isn't working sometimes, or it's working too well sometimes. And by working too well, that means you just have too much of the levodopa in your system. So this graph on the left side kind of explains it pretty well. So the blue triangle right here in the middle, that is when the medication is in your system, it's treating the symptoms, and it's not causing any side effects. So as long as we're in the blue triangle, we're happy. Up here in the orange or the yellow or the gold, whatever color that is when you have enough levodopa in your system, but it kind of borders on too much and it starts to cause side effects such as dyskinesias. Dyskinesias, so let me back up a second. So in Parkinson's disease, there's a lack and a slowness of movement because you don't have enough dopamine. Dyskinesias are kind of the opposite. You have too much dopamine and it makes you move more than you want to. So some people they describe it as getting the wiggles. You kind of have a tough time sitting still. It doesn't bother a lot of patients. It mostly bothers the family and people around people with Parkinson's disease until they become more severe and they start to interfere with things like walking and eating, just because you're moving around so much, it's hard to do those activities. And down here in the purple is when you don't have enough levodopa and you're off, you're stiff, you're slow, you have tremor. So at the beginning of the disease, you take the levodopa, it's the perfect amount, and it slowly, the amount of levodopa slowly goes down. Then you take another tab, and you don't notice anything. In fact, it may be tough to tell if it's working just because it's so good the whole time. As the disease progresses, this window right here, the blue triangle, gets smaller and smaller, and it gets harder and harder to keep the level of levodopa in your blood inside that triangle. So this is where the fluctuations come in. It's like a roller coaster. You start to wear off, you take the levodopa, it takes longer to kick in because you need more levodopa. Then for a short while you're in here, and then you're up experiencing dyskinesias, and it starts to wear off again. So it's just an up and down, and it causes a lot of grief and disability. And here's another way to picture motor fluctuations. So in early Parkinson's disease, you take a dose of levodopa, it goes up, you're doing great, it lasts a long time, and then it wears off, and you've already taken your next dose of levodopa by then, so everything is great. In moderate PD, this is when you start to experience that roller coaster, but it might be mild and not that bothersome. The levodopa you take is still predictable, and that you take it and things get better, although there are side effects. And then in advanced Parkinson's disease, that's when you start to, this is no longer a roller coaster. This is like a car crash. Sometimes it's way too much, and then it doesn't work at all, even though you took it. And then for some reason it does later on. And the dyskinesias get very severe. And here's just a video demonstrating what dyskinesias look like. I can only, I can explain it so much, but here's just kind of what it looks like. So this is a man with Parkinson's disease, and usually you'd be standing very still, but as you can see, he's just kind of rocking back and forth. And he has a particularly severe case where it's starting to interfere with his balance. And aside from medications, just anxiety in general can also make dyskinesias worse. So there's a lot of things that can contribute to them. Treatment strategies for when Parkinson's gets advanced like this and causes these motor fluctuations. There's many things you can do. Number one, you can alter the dose and the timing of the medication that you take. So for example, a lot of people take their levodopa 3 times a day. And when you do that, you may get, high peaks and then low lows when it wears off. And you have big peaks like that. One strategy is just to make it more frequent and a smaller dose throughout the day. So instead of getting these big roller coaster peaks, it kind of smooths it out so you stay in that blue triangle, the on time without dyskinesias, a little better. It's kind of like flattening the curve. That's a term we all know now thanks to COVID. Taking it more frequent with a lesser dose flattens out the curve and keeps you in the good zone. Another thing you can do is switch to longer acting forms of the medication. For example, extended release Sinemet and Rytari are just ways of making the dopamine last longer, and you don't have those high highs and the low lows. You can also add fast-acting, short-lasting rescue medications for those sudden, unpredictable offs, and perhaps those early morning off periods when it takes a while for the carbidopa levodopa to kick in, maybe sometimes up to 30 minutes. Some people use like a fast-acting rescue medication to help them get ready in the morning for work. You can add medications to extend the usefulness of levodopa. It kind of prevents the metabolism and breakdown in the brain to make it last longer. And then we can also add medications that reduce side effects so we can add more levodopa. Usually in medicine, we we try to avoid treating the side effects of a medication with another medication. But Parkinson's disease is one of those diseases where we have to treat the side effects, or else you can't move and you have a low quality of life. And after we've exhausted all those medicine treatments, that's when we start thinking about our more advanced therapies, our surgical options. And there's a couple different surgical options, and it seems like they're coming out with new ideas every year, but the big three are either a continuous levodopa infusion, and that can be done either through a stomach tube and a pump that kind of sits on your belt and just pumps it in continuously throughout the day. And that's how you get the flattest curve possible and remain in that blue zone all the time. There's focused ultrasound ablation that some of you may have heard of, where it's a non-surgical technique, but they kind of burn a small part of the deep part of your brain to make your symptoms better. And then of course there's deep brain stimulation, or DBS. And we can finally start talking about deep brain stimulation. Well, I take that back. A brief history of Parkinson's treatment before we actually get into deep brain stimulation. So in 1817, Parkinson's disease was first described by Dr. James Parkinson. And while we were very good at describing neurologic disease back in the 1800s, especially over in France, there were not a lot of treatments available. And so that's how we had that drawing of that old man from the 1800s that was completely untreated. So no treatment available, but at least we knew what it was. And then finally around the 1950s, that's when we first started doing treatment for Parkinson's disease. And it was not medicine. The first treatment was actually surgical. Around the 1940s and 1950s is when psychiatric surgery started coming out. So like the frontal lobotomy and other types of surgeries were very good for people with schizophrenia and other mood disorders. I mean, they came with side effects, but they did treat the schizophrenia well. So it made them think, what else can we treat with brain surgery? And through some experimentation on animals, they found that destroying or burning small parts of the deep part of the brain really led to improvement of Parkinson's patients in their motor symptoms, things like the tremor, the stiffness, the slowness. And while it did help a lot in some patients, it didn't always work that well, and sometimes it came with severe side effects just because it was the early stages. And the problem with it was that it was, you're burning a small part of the brain. So it's a one and done procedure, and then the effects afterwards you have to live with. So it wasn't an ideal treatment, especially at the time with the technology they had, but it did help. And that continued for a while until 1967, when levodopa was finally discovered and introduced to the market. And levodopa, that was revolutionary. It worked so well and treated the symptoms of Parkinson's. It was like a miracle at the time. And it worked so well that all research into surgeries and other treatments for Parkinson's kind of came to a standstill. And while levodopa does work well, we found that as the disease progresses, it gets harder and harder to use for all the reasons we already talked about. The motor fluctuations, the other side effects that come with it. And we said, maybe we need to go back and look at the surgery thing. And in 1987 is when the first implantation of a DBS for Parkinson's disease was done. And that's when more research into its application started. So DBS is, it's similar to those old ablative surgeries where they would destroy a small part of the brain, except they found that if they just use a lower energy of electricity, they can still treat the symptoms without destroying that part of the brain. The only caveat is that it has to be done continuously instead of a one-time procedure. Then in 1997, the FDA finally approved DBS for use in tremor predominant Parkinson's disease and essential tremor, another disease that can cause tremor. And then in 2002, they finally approved it for more generalized cases of Parkinson's disease, not just tremor predominant. So before we can talk about DBS, just a very simple explanation about the brain. It is basically a network of billions of neurons, change that M to a B right there, that use electricity signals to communicate with each other. And each neuron has dozens or hundreds of connections with other neurons, making trillions of connections in the brain. You can almost think of it like a living supercomputer, just a bunch of wires that connect with each other. And since electricity is the way the brain communicates and functions, we can use electrical stimulation to change the way the brain works. So you can think of, as we said before, the brain as a supercomputer, but in some diseases like Parkinson's disease, you have a short circuit of a certain part of your brain that makes, tremors and your body not listen to you the way it used to. And if we can apply the electrical impulse to exactly where that short circuit is, we can make it work again. And there's several ways to change the electricity in the brain, and that's through medications like levodopa that in a way changes the electrical impulses in the brain, and then this deep brain stimulation. So what is DBS? It is a surgical procedure. It involves implanting electrodes deep in the brain to the part that causes Parkinson's disease, and that delivers very small electrical impulses that alter abnormal neuron activity. A simple way to think of it is, most people are familiar with pacemakers. You can think of it as a pacemaker for the brain. There's an arrhythmia, like in the heart, in the brain, and we just give it a gentle stimulus, and it makes it work normal again. The DBS system comprises, made up of 4 parts. You've got the leads themselves that are implanted by the neurosurgeon deep in the brain, and they're connected by these leads that kind of go up to the top of your scalp. You've got these extension wires that go from the electrodes in your head down to the battery, which is actually installed in your chest, just like a pacemaker, where that would be. And this is the battery, and it also provides the electricity that makes the deep brain stimulator work. And the 4th part, it's not pictured here, but there's a handheld programmer that turns it on and adjusts how it stimulates the brain. What can DBS treat? We mentioned before that it can treat both Parkinson's disease and essential tremor, and that's the first thing it was approved for. But the FDA has also approved it for some other neurologic and psychiatric diseases, such as dystonia, which we briefly hit upon, that can affect some people with Parkinson's disease. It can treat seizures or epilepsy, and it can also treat psychiatric conditions like obsessive compulsive disorder. I remember I was watching PBS, I think it was a couple months ago, and there was a documentary about a man with severe OCD that the medications just couldn't treat. And it was kind of a before and after of how he was treated with DBS, and it was fascinating. I don't usually get to see the psychiatric side of DBS, so I think it's available on the PBS app if you want to go check it out. I recommend it. And these are the things that DBS is FDA approved for. There's a lot of research going on. There's been a DBS revival in the last several years, and everybody's trying to see if it can help their section of neurology. And there's some promise in multiple sclerosis, depression, chronic pain, traumatic brain injuries, Tourette syndrome and tics, recovery from stroke, Alzheimer's disease, addiction disorders, and anorexia. So it's a very exciting time for DBS. And I guess now if it's a question of what can't we help with DBS? But once again, these are still in the research process. So hopefully we see a lot of strides in those areas soon. Now, specifically in Parkinson's disease, what does DBS help with? So the things that DBS helps with are the things that levodopa and the other medications help with. So levodopa is very good at treating the slowness of movement, the bradykinesia, the stiffness, and the tremor. And those are what DBS helps with. I put a star by tremor here because DBS can help with tremor even if the medications don't. And that is the one exception to the rule. It's really good at treating motor fluctuations and sometimes severe dystonia if you happen to have that in addition to your Parkinson's disease. And probably more important than knowing what it helps with is learning what it does not help with. So it does not help with balance, freezing of gait, and I put a star by that because sometimes it does if the freezing of gait gets better with levodopa. It does not help with speech dysfunction, swallowing dysfunction, or your handwriting. It doesn't make that bigger. And most importantly, that I think is important to clarify, this is not a cure for Parkinson's disease. It's just another treatment of the symptoms, just like levodopa. And by now, you're asking, should I consider DBS or would DBS help me? And we find that DBS helps 3 types of Parkinson's patients. Number 1, the patients with severe motor fluctuations, despite exhaustive medication adjustments, like trying longer acting medications, changing the timing, adding others. If all that is not enough, that's who DBS helps with the most. Other people are patients who cannot tolerate higher doses of the medication due to other side effects. So the levodopa would help them, and it does help them, but they just can't take it because of nausea, lightheadedness, and dizziness, or whatever side effect they're experiencing. And then lastly, as we briefly mentioned before, patients with a bothersome tremor that does not respond to levodopa, those people can also benefit from DBS. And then as long as we're talking about the people who do benefit, there's the people who either don't benefit or might want to not do DBS for whatever reason. And that is people who have Parkinsonism but don't have Parkinson's disease. Things like PSP, MSA, corticobascular syndrome, those Parkinson's plus syndromes that you may or may not be aware of. People who have symptoms that do not respond to levodopa, of course, the one exception is the tremor, as we mentioned before. People with severe memory deficit or dementia, people with uncontrolled depression or other mood disorders, people who are unable to have surgery due to another comorbidity like severe heart disease or severe lung disease, things that would make surgery dangerous. And then patients with severely abnormal brains that we find on MRI. And the reason for that is mostly because those lesions may be causing the Parkinson's disease, and that would make you not have Parkinson's. It would be just a Parkinsonism. And then it also makes surgery dangerous. It can cause bleeding if there's a lot of shrinkage of the brain. So now we can talk about the actual process of getting DBS. You've spoken with your neurologist, you did your research on the internet, you listened to some fellow talk about it for 45 minutes, and you decided, yes, I'm interested in DBS. What now? Well, now you have to undergo several steps to determine if you're eligible for surgery. Just because you want it, you have to pass a few tests and talk with a few different people before we can proceed with the surgery. So here's kind of a flow sheet of what it looks like. So first you talk with your neurologist, and then you decide, yes, this is something I'm interested in. Then you do what we call the fast track referral. You talk with the neurosurgeon, you talk with a neuropsychologist, and you talk with psychiatry. And then you start doing all these other tests. And then notice kind of the common part of everybody is discuss expectations, managing expectations, just because, you know, DBS can help a lot of the time, but once again, it's not a cure, and it might not get rid of all your symptoms, but it improves them, but it doesn't get rid of them. So as for all these tests that I was talking about, the first thing we do is called an overnight off-on evaluation. And this can either be done in the clinic with your doctor, or some places do an overnight inpatient hospital admission. And what it entails is we have you not take any of your medications, Parkinson's medications that is, for up to 24 hours. And then when all the medication is mostly out of your system, we do the physical exam. So you know the things we do in the office, you know, we have you tap your fingers like that. We do the rapid movements. We get up and watch you walk. We look at your tremor. We see how bad the Parkinson's symptoms are when you're not taking any medication. We write all that down and we assign a number to the severity of the symptoms. And then we give you a challenge dose of levodopa. And then we do all those tests over again. And then we assign a number to the severity of those symptoms and we compare them with each other. And we say, does the levodopa actually improve your symptoms or does it not? And that's how we determine your levodopa responsiveness. Then we have you see a neuropsychologist. And if you've never done a neuropsychological evaluation before, you meet with a psychologist for either a full morning or an afternoon. It's about 3 to 4 hours. They talk to you about your mood, your goals of wanting to get a DBS. And then they do some thinking tests and some puzzles. And it's several hours long. It can be arduous. I've never done it myself, but it sounds like torture to me. And then they determine, you know, how good your thinking is, and would implanting the DBS, would that cause more problems than it helps? And they are a big part, and we appreciate their input, the psychologists. And of course, you got to get a brain MRI ahead of time to make sure there's no big abnormalities there that would interfere with the surgery. Once you've done all that testing, then all the doctors get together, the neurologist, the neuropsychologist, and the neurosurgeon. We get together, we have a conference, we talk behind your back, we discuss your case and your test results, and we all get together and decide, is DBS right for you? Like, would it help you? Or is there something else that would give us pause and make us think maybe DBS is not right for you? And that's a very important part. The first thing we want to do is avoid harm. That's our number one goal as doctors, is not to hurt, but instead to help. And after all that, if the committee feels that yes, you are a good candidate for DBS, then we'll have you meet with the neurosurgeon again, and you can talk more about the procedure. So our neurosurgeon at UNMC is Dr. Abosh. She just joined our team about 1.5 years ago, but she's certainly not new to DBS surgery. She's been in the field for a very long time. We're very happy to have her here at the University of Nebraska. And in fact, she's the neurosurgery department chair. And she's been past president of the American Society of Stereotactic and Functional Neurosurgery, that basically the Deep Brain Stimulation Society. and she's done a ton of research in the past. This is just an example of her research here at the bottom. She helped develop a method for determining, if we're in the right spot, if you're at the target in DBS. So she's amazing. She's, she's the best, and she's a delight to be around. So we're very happy to have her here. The benefits from DBS, aside from improvement of the symptoms that we talked about before, here's the numbers. It increases on time without troubling dyskinesias by a range of 3 to 4.5 hours per day compared to just taking medicine. So that's a huge increase in the day. Surveys given to patients, they indicate like a 39 to 60% improvement in their symptoms and quality of life. But then again, that's a survey, so you can take that with a grain of salt, but most people are very satisfied with their results. A lot of people are very happy in that they can reduce the amount of medications they take after DBS implantation. And it provides long-lasting benefit. As long as it's in there, it's going to help. But of course, the caveat to remember, Parkinson's disease is progressive. It gets slowly worse with time. And just because the DBS is in there, it doesn't slow down the progression. So even if you have it in there and everything's perfect, the symptoms will eventually come back. It's just a matter of time. And of course, there are complications. The overall complication rate is about 10 to 20%, depending on who's doing the surgery and where you're doing the surgery. At UNMC, our complication rate is on the lower end. It's about 10 to 12%. And most of the complications just come from the surgery itself. Sometimes the lead is misplaced. It's not exactly in the right spot, and you might not get benefit from it. Or there's some kind of hardware malfunction. The lead breaks or something like that, and that happens 2% of the time. About 4% of the time, there is a hemorrhage inside the brain. This is surgery, and we're cutting tissue, so there is bleeding that's not uncommon. Most of the time, it's asymptomatic, meaning, and if we didn't do a CAT scan afterwards, we wouldn't even know. But sometimes the bleeding can be large enough that it causes, a stroke-like picture. You're weak on one side, numb, trouble talking and walking. And sometimes it can be devastating and sometimes lead to death. Of course, that is a much lower percentage of the time than 4%. Infection, both either immediately afterwards or kind of months down the road, is actually one of the more common side effects, depending on the paper you read, 3 to 20% of the time. Sometimes it gets better with antibiotics. Sometimes you got to remove the leads and either do it again or not several months down the road. Seizures can happen in about 1.5% because you're altering the brain, and anytime you change the structure of the brain, it can cause a seizure. And then probably the most common complication is just post-surgical confusion. It's transient, but it can last weeks or even up to months sometimes. Aside from the immediate complications from surgeries, there can be permanent side effects just from placing the leads themselves. So I mentioned before that DBS is good compared to the old destructive surgeries because it's reversible, but we are still making, we're still making a small hole down in the brain so that we can get the electrode there. And sometimes that can cause impaired concentration and difficulty thinking, speech difficulty, and it can slightly worsen your balance and gait too. And sometimes those are permanent. Back to the process. You finally met with the neurosurgeon. You talked about these risks and benefits that we just went over, and you still decided, yes, I want the DBS. Now what? So depending on your surgeon, you may have 2 or 3 separate surgeries, one to put in one lead, another to put in the other lead if you're doing both sides, and then the last one to put in that battery or the pulse generator. Each of them are about 2 to 3 weeks apart to allow you to recover between surgeries. So surgery day finally arrives. What does it entail? First of all, you arrive at the hospital very early, probably around 4 or 5 a.m. And then they place this frame on your head. That's the first thing they do. And the purpose of that is to help guide the surgeons. It's kind of a frame that doesn't move when you move your head. And then they obtain imaging with a CAT scan or an MRI with that frame on, so they can use it to get exactly where they want to go, because it is a very small target that they're hitting in the deep part of your brain. And this makes that possible, that stereotactic frame. She's smiling a lot here, but I hear it's not that comfortable, but she's handling like a pro. And then next you go to the operating room, and there's going to be a lot of people in that operating room. There's going to be the surgeon, the surgeon's assistants, the nurses, the anesthesiologist, the device representative, who does who will turn on the device in the room. And then you may or may not have me in there with you, a neurologist. And that would be me, right? Well, that's not me. That's actually Dr. Oken, one of the pioneers of DBS technology right now. And at least during the implantation of the leads, you will actually be awake during the surgery. So they're doing the surgery back there right now, but as you can see, he's not under anesthesia, he's wide awake. And the reason we do that is not just to torture you. They do provide some topical lidocaine for when they make the incision. The brain itself does not have nerve endings in it. So even though they're putting this probe in your brain, you don't feel a thing from the surgery itself. But the reason we have you awake is so we need to do testing before, during, and after the procedure, just to make sure that we're in the right spot. So all those tests that we have you do in the neurologist's office, the tapping your fingers, the stomping of your foot, the testing of your tone, we do that during the surgery to get a baseline. And then after we put the electrode in and turn it on, we test it again. And there's usually immediate improvement, even in the operating room. So depending on where we put the electrode, the results can be instant, and it's amazing to watch. And sometimes patients get completely better in seconds, and it's amazing to see. And then you come back when they put the battery in, they will put you asleep for that one. There's no reason to be awake for that. After surgery, after each surgery, they'll do a CAT scan of your head again to make sure that the electrode's in the right spot and that there wasn't any bleeding. And then you spend the rest of the day in the hospital recovering and for observation, just to make sure there's not any complications. And then you go home and come back and do it again in a few weeks. So even after you get both the leads and the battery put in, we actually leave the system off for several weeks. And the reason we do that is because when we introduce the electrode into your brain, it causes some swelling, just because we damaged part of your brain. And it swells, and so we have to let that swelling go away because it'll interfere with the electricity if we try and do it right away. So we gotta let your brain heal, and then we can finally turn it on. So the next step is the programming. About 6 to 8 weeks after your last surgery, you'll meet with your neurologist to turn it on and begin programming. In the process of programming, it can take up to 3 to 4 months the first time around. And the reason it takes so long is because there's a lot of fine tuning. We want to find the right amount of stimulation in the correct part of the lead that will improve your symptoms the most but while avoiding side effects. And common side effects from stimulation include numbness or tingling on one side of the body, difficulty with speech, sometimes difficulty with coordination, and sometimes abnormal contractions of muscles or dystonia. And as we mentioned before, all those side effects that come with the stimulation, those are completely reversible. So the pros and cons of DBS. The pros are excellent benefit of levodopa responsive symptoms. So the DBS it pretty much treats the symptoms as good as levodopa does, except it does it over a longer period of time. It can treat medication-resistant tremor, allows you to reduce medications, and any side effects are mostly reversible, except for a few. And the cons, it requires invasive brain surgery, and there's definitely risks associated with that. The majority of patients, while you can reduce medications, most everybody stays on some form of medication. It cannot treat symptoms that levodopa does not treat. It requires multiple visits to your neurologist afterwards for programming. And so if you live like in Scottsbluff or North Platte, that's a 4 or 5 hour drive every couple of weeks to get this thing programmed. Because you want someone who's well trained in programming to do it for you. And of course, it's not a cure for Parkinson's disease. If you want more information, you can talk with your local movement disorders neurologist. There's a lot of good websites out there for hospitals and universities like Mayo Clinic, Johns Hopkins, Cleveland Clinic, and so on. You can pick your favorite famous hospital. And then you can also check out the manufacturer websites. And the big 3 manufacturers of DBS are Medtronic, Boston Scientific, and Abbott, and that used to be called St. Jude for people who are familiar with the older technology. And here's some take-home points. And these are basically the pros and cons I just talked about. And that's what I had for DBS. Any questions that anybody had?
Well,
There's probably a lot of information to take in. Does anybody here have a DBS already in?
well, it's looking like no one has, but
Well, I have a question.
Yeah.
I had the DBS procedure done last March, spring of this year, and we're going through the tweaking process. And the technologist has me put on 2 earphones and asked me to listen and report anything that I hear, like a burning sensation or a static or anything that's unusual. I'm just wondering, and then she increases the current to the system. And she got high enough, I had a hard time breathing. So that was an interesting relationship. But I'm wondering if they're sitting there and you're not hearing much, is that good? And that they've targeted the area they need to target, or do they want to hear lots more anomalies?
So that interesting about the hearing it, usually it doesn't cause any auditory side effects. Like you shouldn't really hear anything. Some people feel like a buzzing inside their head, especially when it's first turned on. That usually goes away after a little bit. But just it turning on makes some people feel a buzz. While we want to avoid side effects, we want to see them, like after we place the lead in during surgery. We crank up the voltage much higher than we would normally have it just in everyday use, because we're trying to elicit side effects. And the reason we do that is it tells us, yes, we're in the right spot. Because the target we have for Parkinson's disease, it's very close to other important parts of your brain that control sensation and movement. So if we turn up the voltage a lot and you don't have any numbness or tingling anywhere or a contraction of a muscle, it makes us think that maybe we're not in the right spot. So experiencing side effects we want to avoid, but just because they happen isn't necessarily a bad thing. It probably means we're close to the right spot, if not in the right spot. But the buzzing in the ears, that's a new one to me.
I should have been clearer. I had trouble breathing.
Well, and then she turned it off.
Then she turned it down, and the problem didn't represent itself. But when she had the pressure up pretty high.
Yeah, sometimes it can cause contraction of muscles, and it wouldn't be out of the question to think it could contract the muscles responsible for breathing. And so that, I assume that's what happened. But thankfully, all the side effects are completely reversible.
I thought it helped to eliminate that channel as the best source of current.
Yeah, if it happens at a low voltage, then we would not want to use that. If it happens before you get benefit, that would be a good reason to not. You know.
Right. It was during testing of the 4 channels.
Oh yeah, the initial mapping.
Select the correct one.
Right. So just because it happens in one channel doesn't mean it's not necessarily useful. Especially if it happens at the higher voltages that we wouldn't be using anyway. So it all depends when it happened and how much power you're using at the time. But yeah, if it caused problems with breathing, that would be a good one to avoid, I think. I agree.
Does anybody else have any questions? No?
I would like to know if there's a copy of this that could be played for. I have a brother that ought to look at this, and I have a friend that needs to look at this. Is there a copy of this that they could go to a website to see? Yeah.
So all the information I have here is pretty much available on any of those university websites.
Okay.
So like if you just type into Google DBS for patients,
right,
it'll provide a ton of great information in it, like from Mayo Clinic or Cleveland Clinic, or even the DBS manufacturer websites.
There's also, this recording will be on the Parkinson's Nebraska's Facebook page.
Okay.
So if you just search up Parkinson's Nebraska on Facebook, this will be the first thing, and you could share that with them as well.
Oh, I don't have Facebook.
Oh. Then I'd go with Dr. Woodward's.
Yeah. I'll have to find out. I have a Diopa pump.
Oh, you do?
Yes. And that's been good for me.
Good. Yeah, and there's no one surgical option for everybody. It kind of depends on what your goals are to get out of treatment. Sometimes the Duopa pump works very well, and it also reduces off time and increases on time without dyskinesias in a lot of people. And you just need to talk with your neurologist to decide which one of them is best for you.
Yes. What I don't like about it, it interferes with my golf game.
With your coffee?
No, golf game. Golf.
Oh,
I'm not,
just because
not
the
a
pump
company.
itself.
All right. Well, if there's no more questions, I want to thank you, Dr. Woodward, for taking the time to show us all of this. And I know I left feeling way more educated than I did before. And
Yes, thank you very much, Dr. Woodward, for joining us.
Yeah, my pleasure. Very good to meet all of you.
all right. Well, if there's no more further questions, then everybody have a good night.
Have a good day, everyone.
Thank you.
Bye-bye.
Bye.
Everybody.